The doctor was shocked when he saw who had been delivered. Evelyn Parker was 45 years old when her body began to behave in ways she could no longer explain. She lived alone in a quiet Midwestern town in the United States, far from major medical centers, and had spent most of her adult life avoiding hospitals unless absolutely necessary. Years earlier, physicians had told her that pregnancy at her age would be extremely unlikely. Her menstrual cycle had gradually faded, replaced by symptoms consistent with perimenopause. Media, calendar pages turning, time-lapse of seasons changing outside window, close-up of woman marking dates on calendar, irregular bleeding, fatigue, night sweats, and hormonal instability. Evelyn had accepted this as a natural transition and believed her reproductive years were behind her. The first change was subtle. Her lower abdomen appeared slightly distended, firmer than before. She assumed it was weight gain, a common complaint among women entering menopause. The firmness, however, felt unusual. It was not soft, not fluctuating, and did not change with diet or physical activity. Still, Evelyn dismissed it. The discomfort was mild, and the idea of something serious felt exaggerated. Over the following months, the enlargement became more pronounced. Her abdomen expanded slowly but steadily, creating a rounded shape that seemed disproportionate to the rest of her body. The tissue felt rigid, almost immobile beneath the skin. She experienced a persistent sensation of pressure, particularly when bending forward or lying flat. Simple activities such as climbing stairs caused breathlessness and discomfort. Eating full meals became difficult due to early satiety and nausea. Despite these changes, Evelyn did not seek medical evaluation. Financial concerns, limited access to consistent healthcare, and years of normalizing pain had shaped her behavior. She had learned to endure discomfort rather than investigate it. Without acute symptoms such as fever or sudden bleeding, she convinced herself that nothing urgent was happening. As time passed, her interpretation of the symptoms began to shift. The abdominal enlargement continued, accompanied by hormonal fluctuations that caused breast tenderness and fatigue. The firmness of her abdomen, the sense of fullness, and the gradual bodily transformation began to resemble what she imagined pregnancy might feel like. The thought seemed irrational at first, yet it persisted. Against medical probability, Evelyn started to believe that her body was doing something extraordinary. The idea of a late, unexpected pregnancy took hold slowly, reinforced by physical sensations she could not otherwise explain. She did not feel fetal movement, but she rationalized this as an unusual presentation. The absence of confirmation became irrelevant in the face of what her body appeared to be telling her. Her abdomen continued to grow, not rapidly, but relentlessly. With it came a mix of fear and fragile hope. The discomfort intensified, yet the belief remained. Something inside her was changing, and she believed it was life. By the time Evelyn's abdomen had reached a size comparable to late pregnancy, her physical condition had deteriorated significantly. The abdominal wall felt tense and unyielding, unlike the elasticity expected in a normal gestation. The mass beneath the skin did not shift with position or movement. It remained fixed, heavy, and dense. Chronic pelvic pain became part of her daily life, sometimes dull and tolerable, sometimes sharp and exhausting. Evelyn experienced intermittent cramping sensations that radiated into her lower back and thighs. These episodes increased in frequency and intensity over time, reinforcing her belief that her body was preparing for labor. At night, the pressure worsened, making sleep difficult. She often lay awake, focusing on the sensations, attempting to interpret them through the lens of pregnancy rather than pathology. There was no prenatal care, no blood tests to measure pregnancy hormones, no ultrasounds to confirm gestational age or fetal development. The absence of medical oversight allowed misinterpretation to flourish. Evelyn relied entirely on physical perception and emotional reasoning. The idea that her symptoms could be caused by something rare or dangerous never fully surfaced. In reality, the signs were inconsistent with a viable pregnancy. The lack of fetal movement, the extreme rigidity of the abdomen, and the absence of physiological changes typical of late gestation were red flags. However, without diagnostic imaging or laboratory evaluation, these inconsistencies remained unchallenged. As months passed, Evelyn's condition worsened. She developed persistent gastrointestinal discomfort, constipation, and a sense of internal compression. Her posture changed as her body attempted to compensate for the altered center of gravity. Fatigue became constant. The physical burden affected her mental state, creating anxiety mixed with anticipation. The first severe episode occurred late one evening when intense cramping pain seized her lower abdomen. The pain was unlike anything she had experienced before. Deep, forceful, and rhythmic. It subsided after several hours, only to return days later with greater severity. Evelyn interpreted these episodes as contractions. The belief that labor was approaching became absolute, when the pain finally became unbearable, continuous and incapacitating. Emergency services were contacted. By then, Evelyn was convinced that she was about to give birth. Her body felt overwhelmed, strained beyond its limits, responding to something it could no longer contain. What she did not know was that there was no developing life inside her. What her body carried was not a future, but a past that had never been resolved. Evelyn Parker arrived at the emergency department shortly after midnight. The paramedics documented severe abdominal pain, suspected late-stage pregnancy, and complete absence of prenatal records. Her age immediately categorized her as a high-risk patient. At 45, with no documented obstetric history and unclear gestational timeline, the case triggered concern across multiple departments. Initial assessment revealed an abdomen that was markedly enlarged but unusually rigid. Palpation did not produce the expected uterine contour associated with advanced pregnancy. The abdominal wall felt tense, resistant, and fixed. Vital signs showed mild tachycardia and elevated blood pressure, consistent with pain and physiological stress rather than acute hemorrhage. Laboratory results indicated chronic inflammation, but no markers of acute infection or pregnancy-related complications. Given the working assumption of a possible non-viable or complicated pregnancy, obstetric imaging was ordered immediately. A transabdominal ultrasound was performed under suboptimal conditions due to the density of the abdominal contents. The images were confusing and inconsistent. No identifiable fetal heartbeat was present. No amniotic fluid pocket could be visualized. Instead, the ultrasound revealed extensive hyperechoic regions, producing strong acoustic shadows. The findings were atypical. Calcified structures within the abdominal cavity reflected the ultrasound waves, obscuring deeper visualization. The mass appeared large, irregular, and immobile. The uterus itself did not appear gravid, though distortion from surrounding structures made interpretation difficult. The radiologist noted that the imaging did not align with a normal late-term pregnancy. Differential diagnoses expanded rapidly. Advanced uterine fibroids were considered, though the degree of calcification and rigidity seemed excessive. An ovarian neoplasm was discussed, as were complex abdominal tumors. A chronic ectopic pregnancy was briefly mentioned but not prioritized due to its rarity. The absence of clear fetal anatomy made pregnancy increasingly uncertain. Despite the ambiguity, Evelyn's escalating pain necessitated intervention. Conservative management was no longer viable. The medical team concluded that surgical exploration was required to prevent further deterioration. The procedure was categorized as high risk due to the unknown nature of the mass, potential adhesions, and Evelyn's age. Dr. Andrew Collins, the attending obstetrician-gynecologist, reviewed the imaging multiple times before consenting to surgery. The calcification pattern disturbed him. It did not resemble typical gynecological tumors. The density, symmetry, and encapsulation suggested something else, something rarely encountered in modern clinical practice. A memory surfaced from his early residency years, a lecture on rare obstetric phenomena, discussed briefly and largely dismissed as historical curiosities. As the operating room was prepared, uncertainty dominated the clinical atmosphere. The team moved forward without a definitive diagnosis, aware that the surgery could reveal anything from malignancy to catastrophic internal pathology. Upon entering the abdominal cavity, it became immediately clear that the pre-operative assumptions had been incomplete. The uterus was not enlarged in the manner expected of a late-stage pregnancy. Instead, it appeared compressed and displaced. Surrounding it was a massive encapsulated structure occupying much of the lower abdominal and pelvic cavity. The mass was rigid and irregular, with extensive calcification visible even before full exposure. Dense fibrous tissue connected it to surrounding organs, including sections of the peritoneum and adjacent bowel. The surgical team proceeded cautiously, aware that aggressive manipulation could result in hemorrhage or organ damage. As the encapsulation was carefully dissected, the nature of the mass became unmistakable. Beneath layers of calcified tissue lay preserved skeletal elements arranged in a configuration that could not be mistaken for a tumor or fibroid. The structure was anatomically recognizable. The diagnosis was immediate and absolute. This was a lithopedion, a stone baby, the remains of a fetus that had died many years earlier, likely during an undiagnosed extrauterine pregnancy. Unable to expel the fetal tissue, Evelyn's body had responded with a protective mechanism. To prevent infection and systemic inflammation, calcium salts had gradually deposited around the remains, isolating them from surrounding tissue. Over time, the fetus had transformed into a hardened, biologically inert mass. The calcification process had taken years, even decades. As it progressed, the lithopedion increased in size and rigidity, slowly altering Evelyn's abdominal anatomy. The gradual expansion explained the long-term distension, chronic pain, and pressure symptoms she had experienced. The rigidity accounted for the immobility and abnormal firmness of her her abdomen. This was not a recent event. This was not a current pregnancy. It was the physical remnant of a pregnancy lost long ago, preserved by the body rather than expelled. For Dr. Collins, the recognition carried profound weight. He had seen images like this before, buried deep in medical literature and training modules. He had never expected to encounter such a case in active clinical practice. The rarity of lithopedion in modern medicine made the discovery extraordinary, but the circumstances that allowed it to occur were tragically familiar. Missed diagnosis, lack of follow-up, and limited access to healthcare. The surgical team completed the removal with meticulous care. The operation lasted several hours. By the time the procedure concluded, the truth was undeniable. What had been perceived as an imminent birth was in fact the unveiling of a condition that had existed silently for years. Evelyn Parker had not been carrying a new life. She had been carrying the unresolved remains of the past. Post-operative imaging and pathological examination confirmed the diagnosis beyond doubt. The mass removed from Evelyn Parker's body was a fully developed lithopedion, a rare and well-documented medical phenomenon. The degree of calcification indicated that the fetal demise had occurred approximately 15 to 20 years earlier. Skeletal structures were preserved within layers of calcium deposits, formed gradually as a protective response by the body to prevent infection and systemic inflammation. Medical analysis suggested that the original pregnancy had been extrauterine, most likely abdominal. Such pregnancies can progress unnoticed when symptoms are mild and access to diagnostic imaging is limited. In Evelyn's case, the absence of acute hemorrhage allowed the pregnancy to end silently. Without medical intervention, the fetal tissue could neither be expelled nor absorbed. The body adapted by isolating it. Over the years, the lithopedion altered Evelyn's internal anatomy. Organs shifted, connective tissue thickened, and the abdominal wall expanded slowly. Hormonal changes associated with perimenopause produced symptoms that mimicked pregnancy, reinforcing a false interpretation of her condition. The gradual nature of the process allowed the pathology to remain hidden until the physical burden became unbearable. Post-operative imaging and pathological examination confirmed the diagnosis beyond doubt. The mass removed from Evelyn Parker's body was a fully developed lithopedion, a rare and well-documented medical phenomenon. The degree of calcification indicated that the fetal demise had occurred approximately 15 to 20 years earlier. Skeletal structures were preserved within layers of calcium deposits, formed gradually as a protective response by the body to prevent infection and systemic inflammation. Medical analysis suggested that the original pregnancy had been extrauterine, most likely abdominal. Such pregnancies can progress unnoticed when symptoms are mild and access to diagnostic imaging is limited. In Evelyn's case, the absence of acute hemorrhage allowed the pregnancy to end silently. Without medical intervention, the fetal tissue could neither be expelled nor absorbed. The body adapted by isolating it. Over the years, the lithopedion altered Evelyn's internal anatomy. Organs shifted, connective tissue thickened, and the abdominal wall expanded slowly. Hormonal changes associated with perimenopause produced symptoms that mimicked pregnancy, reinforcing a false interpretation of her condition. The gradual nature of the process allowed the pathology to remain hidden until the physical burden became unbearable. From a clinical perspective, the case highlighted how rare conditions can persist in modern healthcare systems when routine follow-up and imaging are absent. Lithopedion is uncommon not because it cannot occur, but because it is usually detected earlier. Evelyn's case represented the convergence of biological rarity and systemic gaps in care. Physically, Evelyn recovered well after surgery. Chronic pain diminished, gastrointestinal symptoms resolved, and mobility improved. Psychologically, the impact was far more profound. The belief that she had been pregnant collapsed into the realization that her body had been carrying the preserved remains of a long-lost pregnancy. The emotional attachment she had formed in recent months intensified the sense of loss, despite the pregnancy having ended years earlier. Psychological support became an essential part of her recovery. The experience disrupted her trust in her own bodily perceptions and challenged her understanding of time, loss, and identity. Healing extended far beyond surgical success. For the medical team, the case prompted internal review and professional reflection. It served as a reminder that medicine must remain attentive not only to what is common, but also to what is rare yet possible. Delayed diagnoses do not always announce themselves dramatically. Sometimes they grow quietly over years. Evelyn Parker was eventually discharged with long-term follow-up care. Her body was finally free of what it had carried in silence for decades. What remained was knowledge of how the body protects itself, how assumptions can mislead, and how medicine sometimes uncovers not something new, but something that has been there all along.